Hello friends, this is a case of diagnostic laparoscopy and the hysteroscopic submucous myomectomy and the tubal patency test of a patient who has approximately 2.5 centimeter grade 0 submucous myoma. So we are doing the suction irrigation and hanging drop test, and we can see that this hanging drop is positive, and now we will start insufflating the abdomen. So here the plan is that first you will do diagnostic laparoscopy to rule out everything is fine, and after that we will do hysteroscopic resection of the myoma, and after that we will do tubal patency test also with the ICG. So this is very important that if you are doing any operative hysteroscopy, then together if you will do diagnostic laparoscopy, you have a lot of advantage. First of the advantage that you can rule out almost all the tubal causes of the infertility, and in one session, in one anesthesia, you can complete the all the fertility tests. So that's why it is important. And moreover, if you will perforate, suppose accidentally in the submucous myomectomy, then also you will know that what you did. So we can see that slowly insufflation is started, and we are keeping here the preset pressure 15, actual pressure slowly is reaching to 15, and we can see homogeneous distension is started in the abdomen. And when you do that, then you should be very careful that here we are using the 10 port for the telescope, and we will use only 5 port, that is on the right iliac fossa, for the diagnostic laparoscopy part. So this is the 10 port, and we are, as you know, that we hold it like a pistol, and the index finger is pointed towards the sharp end. Thenar eminence should rest over the head of the trocar, and index finger pointed, and then slowly we are entering inside the abdomen. Hissing sound is heard, telescope is introduced, and then we will put the second port, that is in the right iliac fossa, and then we will start diagnostic laparoscopy. So this is the second port, that is 5 mm. In here our assistant is putting the second port, and this is always under vision. So telescope is introduced, and then it is under vision incision, and this second port is introduced. So diagnostic laparoscopy, as you know, that two port is essential, so that you can manipulate the organ, you can shift the bowel up, you can lift the ovary. So now patient head is 30° down, and we are first step what we will do, that we will sweep all the bowel. Here we can see that this is the medial umbilical ligament, this is the inferior epigastric vessel which is visible, this is the deep ring, and this is medial, this is median in the midline, and this is another medial, and this is another inferior epigastric vessel. So everything anterior abdominal wall is fine. This is the momentum and a small bowel. So in front is the bladder. After that, once our port is introduced, then we will sweep all the bowel above the shackle promontory, so that up to the aorta. And we should take care that sigmoid colon should not be pushed up, only a small bowel should be swept up towards. So it is slowly going above the aorta and above the, this is sigmoid colon, and these are the small bowel. So we can see it is near the aorta, and these are the aortoiliac axis, where common iliac is bifurcating into two common iliac vessel, and in it is just down in the below the screen you can see aorta, and this is the common iliac vessel of the right side is visible, and in the middle there is aorta. So everything is fine, and there is no endometriosis, there is no any inflammation, there is no any tuberculosis. This is sacral promontory, you can see, and here in the middle you can see median sacral vessel is also visible. So this is the common iliac vessel, and this is the ureter which is crossing the common iliac vessel. You can see the peristalsis of ureter is visible, and here the peristalsis is visible, and now this is ureter. So this is the internal iliac is below, and here is the pulsation of internal iliac. Here is the bifurcation of external and internal iliac is clearly visible, and below is the ureter. So this is the laterally going external iliac artery, below is internal iliac, and medially there is a external iliac vein. So this is the also called triangle of doom, because this area you have to be very careful that you should not injure any structure in this area, otherwise major bleeding can happen. And ureteric peristalsis is also visible in below. So this is the right side, and after that we will see the triangle of doom. Here is the IP ligament, and this is triangle of doom. Apex is deep ring, medially round ligament, and here you can see this is the deep ring where round ligament finishes. And this area you will get this is psoas muscle, and here is the GFN, genital branch of genitofemoral nerve, that also will be visible. And laterally you can see the LFCN, that is lateral femoral cutaneous nerve of the thigh, and this area is called triangle of pain. And that area, if you will injure, then you will have the pain on the lateral aspect of the upper thigh and the skin around the hip joint. These are the nerves which is going. So these are the triangle of pain area, which also you have to be careful and you should not injure. After that, this is the psoas muscle, and here is the external iliac artery. This is external iliac, and this is vein, external iliac vein. Vein is medial, artery is lateral, and this is the deep ring. And here is the inferior epigastric vessel, which is taking a branch of inferior epigastric. It comes from external iliac artery and vein. This is the medial umbilical ligament. Here is the Cooper ligament, and this area belongs to in between two medial umbilical ligament bladder. This is sacral promontory, and the middle of the sacral promontory you can see median sacral vessel is also visible. So this is the blue color. You can see this is the median sacral vessel, and this is the sacral promontory. And once you will put the sigmoid colon towards the left side, you can see this is IP ligament, and this is ovary. Just to get the ovary, you lift the ovary and tube with the IP ligament, and you will get it. This is left side of the ovary and the tube. So everything is fine. Anatomy looks good. There is no any endometriosis. There is no any other pathology. No adhesion. This is the left ureter. So this is the right ovary. This is fine. The right tube also look very good. And this is the IP ligament, and this is the IP ligament of the left side. Left ovary also looks very good. And this is the left ureter. You can see this is the left ureter is crossing the common iliac vessel. Right ureter crosses the external iliac. So this is the peristalsis of ureter of the left side will be also visible. So this is the normal anatomy. There is no any. This is the peristalsis you can see. So this is the mesosigmoid, and these are the external iliac artery and vein of the left side. So diagnostic laparoscopy is almost complete here, and no any pathology, nothing is found. Sigmoid is also good, and the cul-de-sac is also fine. And this is the internal iliac artery of the left side, and vein is also visible, medially vein, laterally external iliac artery. So these all structures are good enough, and this is the ureter is the most medial, which you can see the peristalsis. So now this is cul-de-sac. Uterosacral ligament is also visible. There is some fluid in the cul-de-sac. That is normal, but you can take the histopathology if you want. Now this is the resectoroscope, and this is resectoroscope is made up of 5 important things you will assemble together, and then it will be called resectoroscope. What are the component of resectoroscope? Already we know that there are 5 component which is there in resectoroscope. First is telescope, second is outer sheath, third is inner sheath, fourth is working element, and fifth is electrode. So first you will put the electrode in the working element, and after that you will put the inner sheath, and then you will fix the inner sheath. After that you will put the outer sheath. So this is the outer sheath which will be attached, and then at last you will introduce the telescope. So once the telescope is introduced, now this resectoroscope is ready. And there are 2 type of resectoroscope, active as well as passive. So we have fixed the resectoroscope now, and now we will dilate the cervix with the 5 number of Hager dilator. And if you are doing operative, you may have to dilate up to 9 number of Hager dilator. And this is the Hager dilator, we will put it. And mesoprost already we have given 2 hours before the procedure in the OPD itself, and mesoprost is essential because it will make the cervix soft and then you can introduce the resectoscope. And once you before resectoscope, you should also introduce one diagnostic hysteroscopy. So make it sure that you can see all the structure and that is clear. And after that, you should introduce the resectoscope. So this is the 4-channel diagnostic hysteroscope, and that we are introducing, and here it is slowly introduced. After that, we will do the diagnostic, and then we will slowly introduce the resectoscope. Here the pressure we are using approximately 150 millimeter of mercury pressure, and here we can see there is a submucous myoma. Now you can identify it, and you can try to see both the ostia. If you will go very carefully down there, then you can look for the ostia also. And this is the ostia of the right side, and here this is the ostia of the left side. Both the side ostia is good, and it is a fully pedunculated myoma. So in those situations, you don't have to worry, you can easily cut it. So here this is the loop electrode, and slowly you have to go towards the dark and then come to bright. So here you will hook, look and cook. You will go all the way, and then slowly you will start resecting the submucous myoma. During resection, you should try that a small chip should be taken, and the wattage approximately 120 watt we use. However, your how much wattage you are using, that also depends upon your frequency of electrosurgical generator. If you have a high frequency generator, you can use less watt, but low frequency generator need more wattage. And slowly this resection should be continued. You should must see the texture gradient, and only cut the part which texture is dark. Once you reach to the surrounding endometrium, then you can compare the texture of the surrounding from the myoma, and then you should stop. We should not try to dig the myoma, and you should also not go beyond the outer circular layer, and you should only cut the myoma, and then once you have the internal longitudinal layer, we should stop. Because if you cut the outer circular layer, you will enter into the venous plexus and you will have a lot of bleeding. So slowly this is resection is complete, and it was a very easy small, so it is over. After that we will remove it, and now again we are using the HSG cannula, and then we are injecting the ICG. Indocyanine green is nowadays we use in tubal patency test. We don't use methylene blue because ICG has a different mode. This is the digital enhancement, and it is enhancing the image. And after that, you can tell the assistant to inject the ICG, and you can see this is that fimbria, it is coming. Dye is coming on the both side. This side also dye is coming. You can take a atraumatic grasper and you can lift the tube, and you can see the dye, and then you can change the different mode. ICG has the contrast mode, ENV mode, CSF mode, and the overlay mode. So they can scan both the side. The ICG is nicely coming, and then you can change to contrast mode. Once you change the contrast mode, entire lumen of the tube also can be nicely visible, white color, and then you can lift the tube and you can examine the entire tube architecture, and kinking or the any twisting also can be seen, and this is good. So another advantage is this is iodine based dye, so it doesn't react with the body, with the abdomen. So once the diagnostic laparoscopy and this tubal patency test is over, after that what we will do, that we will put some suction and suck all the extra fluid. After that we will suck it, shake it, and some extra, because during hysteroscopy some extra fluid also has come, that you will suck, and after that you can leave some of the fluid inside, approximately 5 to 1 liter of the fluid. Ringer lactate or normal saline you can lift inside, and you can remove your telescope. So this is over. So thank you very much for watching this video. This was just a simple case of diagnostic laparoscopy together with the hysteroscopy and tubal patency test.